My name is Aziz-ur-Rehman and I am Professor of Medicine and I'm going to talk about diabetes insipidus today. Uh, First of all, let's have an overview of all antidiuretic hormone related disorders. There are basically two groups. Any hormone can be in excess or it could be deficient. Now, if there is a deficiency of antidiuretic hormone, it would result in diabetes insipidus. And we know two types. Without specification, it would refer to central diabetes insipidus. That means the problem is in the posterior pituitary. An antidiuretic hormone is not being secreted in proper quantity, and that results in diabetes insipidus. But sometimes ADH may be present in sufficient quantities, but there is some problem with the kidneys, and kidneys are not responding to ADH, and patient has the symptoms of diabetes insipidus. So we have two types, and whenever antidiuretic hormone is in excess, that condition is called syndrome of inappropriate ADH secretion. Actually, syndrome of inappropriately high ADH secretion, you could call it. Now, this is actually not an entity in itself. It is usually a complication of another serious disease, and usual manifestation is unexplained hyponatremia because of water retention. There is too much ADH in the body and that retains water in the body, and patient may not develop edema actually or other signs of volume overload, but extracellular compartment is expanded. Total serum sodium contents may be normal, but when you measure serum sodium, it will be low. So there will be hyponatremia as a manifestation of syndrome of inappropriate ADH secretion. Now, there are other causes of hyponatremia, but that we will discuss in some other lecture. Today, our focus is diabetes insipidus, both central as well as nephrogenic. What is the definition? It is a condition which is characterized by massive polyuria. Our urinary output varies from as little as 1.5 liters to sometimes 3, 4, 5 liters in different persons depending upon our water intake. So, but with average water intake, if patient water intake is not too much but still passes a lot of urine, and that is one requirement for the definition. And if this is due to deficiency of antidiuretic hormone, then it will be called central diabetes insipidus, or as I mentioned earlier, it may be due to non-functioning ADH. ADH is there, but for some reason it is not doing its function on the kidneys, usually problem with the receptor in the kidneys, and that is called nephrogenic diabetes insipidus. So basically a condition where there is massive polyuria without any other cause, and the problem is either in the pituitary gland or in the kidneys. Now, this is the picture which will explain how this thing happens. Antidiuretic hormone is produced by the posterior pituitary. It is actually synthesized by the hypothalamus, brought down to the posterior pituitary where it is where it is stored and released as and when needed in just the right quantity. What is the role of antidiuretic hormone? It actually works on the distal tubule and it allows water to be reabsorbed. Our interstitium in the kidney is very, very hyperosmolar. There is a very, very concentrated environment here. And if water is simply allowed to be absorbed because of ADH, it will be absorbed and then that water will not go on to the urinary bladder. So this is a hormone which preserves our water. In the absence, water will not be absorbed and it will go on into the down the tubules and into the urinary bladder, and that will result in polyuria. The other cause is nephrogenic, when antidiuretic hormone is sufficient but there is a problem with the kidneys and the kidneys is not responding, and despite having adequate level of ADH, water is not reabsorbed. It is usually secondary to another kidney disease or sometime idiopathic, we will discuss shortly. Now, what will happen? It will result in stimulation of thirst mechanism. We have a very efficient thirst mechanism which tells us how much water we need to drink, and if there is polyuria, that will result in some dehydration, and that will stimulate our thirst mechanism, and patient will drink a lot of water. So patient could actually present with this symptom of excessive thirst, or patient could present with symptom of excessive urination, or mostly both. So this is the pathogenesis of diabetes insipidus. Now let's discuss the symptoms. The first symptom is polyuria. First of all, I think students need to understand the difference between polyuria and frequency of micturition. Frequency of micturition usually occurs due to some bladder disorder or prostate disorder or some infection. Patient simply passes urine too frequently, but it is usually in small quantities. But polyuria is a condition where patient passes urine frequently but in large quantities. So to fulfill the definition, it has to be more than 3 liters per day. Of course, there may be a milder case of diabetes insipidus where patient may not have this much of polyuria, maybe lesser degree of polyuria, but by definition, when somebody passes urine more than 3 liters per day, then we formally call it polyuria. And of course, you need to rule out other causes. First of all, I think you need to actually have some idea, is it truly polyuria or not? Now, I have seen in my practice, patients complaining of having excessive urination. So if you want to confirm really if it is polyuria, then you need to measure the urine. So one way is to ask them to buy a big bottle, and this bottle can be obtained from the store of kitchen stores where they sell the kitchenware. So one large bottle can be bought, and patient may be asked to void urine at particular time and discard it, and then from that time onward for next 24 hours patient is asked to collect urine and measure it at the end of the day. Now many times I have seen that patient has complained of polyuria, but when we actually measure it, the urine volume is within the normal range, which is like 2 liters, 1.5 liters, something like that. So I think if you're not sure if it is truly polyuria, you may actually ask the patient to measure the total amount of urine in the 24 hours. Uh, Once you're convinced that this is polyuria, then you also have to rule out the simple causes. The patient may be taking a diuretic. So I think before you undertake the investigation for possible diabetes insipidus, you need to rule out these simple possibilities. Then there will be polydipsia. Now, of course, once there is polyuria, there would be dehydration if somebody's thirst mechanism is intact, and there should be no problem with the thirst mechanism in diabetes insipidus, because diabetes insipidus is the disease of posterior pituitary gland, where our thirst mechanism is in the hypothalamus. So hypothalamus will respond appropriately and will stimulate water intake. And that water intake, of course, will become a symptom as polydipsia, but is actually a corrective measure. Patient may be drinking adequate amount of water so that there is no actual dehydration. But whenever patient is deprived of water for whatever reason, patient does not have access to water, patient will develop dehydration. And this dehydration can be very serious, because patient will continue to pass dilute urine. Even if there is severe dehydration, it could be very serious if patient becomes deprived of water. Now in our religion, because patient fast during Ramadan, so I ask simple question, if I'm not sure if it is true polyuria or not, if I ask them, if can you fast, if they say yes, we can fast without any issue. So that I think simply rules out diabetes insipidus, because person with diabetes insipidus will probably not be able to fast, because he will be practically deprived of water for long hours, and he will develop serious dehydration and clinical feature. So if somebody says that he can fast easily and complain of polyuria, I think it may not be true polyuria. Laboratory abnormalities, serum osmolality needs to be measured. It is likely to be highish, not necessarily high, because patient is taking water also. Normal osmolality is between 275 and 295. Our thirst mechanism and ADH mechanism is very efficient to keep the serum osmolality within a very narrow range. Now, in this patient, the serum osmolality is likely to be in the higher side of the normal range or higher than normal because of slight dehydration. Urine osmolality is low. In normal person, urine osmolality varies depending upon our water intake. First time in the morning when we pass urine, that is little concentrated. So our osmolality may be on the higher side, and this is the normal range from 75 to 1500 milliosmoles per kg. So in the morning or whenever we don't drink water for long hours, especially during fasting, for example, so the osmolality is likely to be in the high range, and when we drink a lot of water, it is likely to be in the low range. In diabetes insipidus, you would expect urinary osmolality to be lower than normal or at least in the lower normal range. So these two things, and hypernatremia would be present in those cases who are deprived of water. There may be again sodium is likely to be on the higher side of the normal range, but if someone is deprived of water, then it could be actual hypernatremia. It could go up to 160, and hypernatremia is a very toxic condition, and somebody going to the extent of 160 may become very serious. So, these laboratory abnormalities may help you to suspect diabetes insipidus, but none of them is very specific. So we have to proceed with further tests. What is the etiology? We have two types of diabetes. One is diabetes insipidus, one is the central, and the other is nephrogenic. In central diabetes, many times we are just unable to determine the cause. Perhaps there is some congenital problem with the production of antidiuretic hormone. The enzymes required for the production of antidiuretic hormone are lacking or deficient, so it could be purely idiopathic, or any trauma to the head, to the pituitary gland, could cause diabetes insipidus. Some infection can also cause diabetes insipidus. Hemorrhage into the pituitary fossa can cause diabetes insipidus. Infiltration of the pituitary gland with histiocytosis X, with amyloidosis, with lymphoma, leukemias, all these conditions can cause diabetes insipidus. Sometimes diabetes insipidus is a temporary condition after head trauma or infection. There is a transient state of diabetes insipidus, but once infection is over, the pituitary recovers, the hypothalamus recovers, and diabetes insipidus goes back. When it comes to nephrogenic diabetes insipidus, it may be again idiopathic. We don't know the cause, but theoretically the receptors on the collecting tubules, receptors for the antidiuretic hormone are deficient or absent. Then many kidney diseases like polycystic kidney disease, some interstitial kidney diseases, and other kidney diseases, one component may be inability to concentrate urine, and especially when the tubules are affected, that may also qualify for the definition of nephrogenic diabetes. Then some drugs which were given for some other reason, and one such drug is lithium, and lithium is given for psychiatric disorder. If somebody comes with polyuria and you suspect diabetes insipidus, ask him if he is taking lithium, and if a patient is taking lithium, that could be one possible cause. Now, of course, you don't straight away stop lithium, then you discuss it with your psychiatrist, and he will decide if lithium is absolutely essential or can be substituted with another drug. Some electrolyte abnormalities like hypercalcemia and hypokalemia can also cause nephrogenic diabetes. So we have a number of causes. As I said earlier, If we do not specify, if somebody just says diabetes insipidus, it refers to the central diabetes insipidus. And if somebody does not refer to a specific cause, it means idiopathic diabetes insipidus. Differential diagnosis, there are several stages of differential diagnosis. First of all, you have to decide, is it truly polyuria, not frequency of micturition. So the question you ask is it that you pass large amount of urine every time and you pass urine very frequently, or is it you pass urine very frequently but it is small in quantity? So that will tell you, is it polyuria or it is frequency micturition. Then, as I said, you have to measure urine 24 hours. If it is more than 3 liters, then it is polyuria, which qualify for the definition of further workup. If it is less than that, it may be just normal for that person. And then the second step is diabetes insipidus versus other causes of polyuria. Diuretic, for example, can cause polyuria. Uncontrolled diabetes mellitus can cause polyuria. Some other electrolyte abnormalities like hypercalcemia can cause polyuria. So we have to rule out other simple causes of polyuria. There is polyuria, but we need to rule out other causes, especially diuretic. So that is the second step. Once we do this, we are sure that patient has are very likely to have diabetes insipidus. Now, and the third step is to differentiate true diabetes insipidus from a condition which is called primary polydipsia. This used to be called psychogenic polydipsia also. Patients with diabetes insipidus, they have two cardinal symptoms, polyuria and polydipsia. And patients with polydipsia also have the same two symptoms. They have, because of some psychiatric problem or because of some unknown cause, they just drink too much water. So the primary problem here is drinking too much water. But if you drink too much water, then of course your kidneys will respond appropriately by excreting a lot of urine. So this patient will also have the same symptom. So in these two conditions, diabetes insipidus and primary polydipsia, you are confronted with a situation where patient has polyuria as well as polydipsia. So in this, polyuria is primary and polydipsia is corrective. In this condition, polydipsia is primary and polyuria is secondary and corrective. So I think we will differentiate, and there is a technique how to differentiate between the two. If you are unable to differentiate, I believe you should guess that this is diabetes insipidus. Then once the diagnosis of diabetes insipidus is made, then we have to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus. So this is how we go along, and starting from this step, do we have to go through all these 4 steps to be able to make a correct diagnosis of central diabetes insipidus or nephrogenic diabetes insipidus? These 2 steps are simple, but I'm going to talk about these 2 steps in some more detail in next slides. Now, clinical features of diabetes insipidus and primary polydipsia are the same, but in diabetes insipidus, the primary problem out of these 2 is polyuria. Patient does not have antidiuretic hormone, or patient does not have enough antidiuretic hormone, or whatever antidiuretic hormone patient is having is not working. So primary problem is polyuria. Patient passes a lot of urine. And then as a correction, because our thirst mechanism is intact, patient will pass a lot of urine and that will result in polydipsia. Patient will have to drink a lot of water and that will result in polydipsia. So we have a combination of polyuria and polydipsia, but primary problem is polyuria. Polydipsia is secondary and is actually corrective. If patient is deprived of water, patient will develop dehydration. Now this actually provides the principles of water deprivation test, which I will discuss in next slide. So basically what you need to understand is that in diabetes insipidus, polyuria is the primary issue, polydipsia is corrective measure, Now, if polydipsia is blocked by water deprivation, patient will develop dehydration. Or if in normal life patient does not have access to water, the patient will develop dehydration. Now, let's take the example of primary polydipsia. Here, the primary abnormality is polydipsia. Due to some unknown stimulus, we believe it may be psychogenic, but it may turn out to be some physical problem. I think there are theories that there is actually, this is also a physical problem, that there is a problem with the thirst mechanism, and the thirst mechanism is not working, is not controlling our thirst, and it is stimulating our thirst all the time, forcing us to drink water in primary polydipsia. So that is a symptom, and in this case polyuria is there, but polyuria is a corrective measure. When we drink too much water, there will be too much water in the body, and that will be sensed by our osmoreceptors and our pituitary, and then that would result, the kidney will respond appropriately by excreting extra amount of water, which will result in polyuria. Now, in this case, if we stop water intake, it will not result in dehydration because patient does not have other problem. Once patient stop drinking water, it will be, status of hydration will be normalized, and there will be no further polyuria. There will be no further polyuria, and there will be no dehydration. Of course, if this polydipsia is very, very prolonged, and for some time kidneys have forgotten how to concentrate urine, despite water deprivation, patient may continue to pass dilute urine for some time, but ultimately it will be corrected. So this is, I think this concept is important to understand the differences between diabetes insipidus and polydipsia, primary polydipsia, and this will also help you to understand water deprivation test. Now, this is water deprivation test. What is it? You admit the patient, and this has to be under observation. Very important. You deprive him of water, or you restrict him, or you restrict water intake, but under observation. Very, very important. Why? Because if this patient has 2 diabetes insipidus and you tell him not to drink water, and at home he may develop severe dehydration and severe hypernatremia and may actually die. So you have to put him under observation. Either you formally admit him or you at least keep him under observation, and you monitor his urine volume, hourly urine volume, and you monitor his osmolality, both serum and urinary osmolality, and you also measure his weight, because that is one of the criteria when to end the test. All right. So the concept of water deprivation is to admit the patient and observe under observation that what happens if we restrict his water intake. Now, interpretation: if patient had diabetes insipidus, in diabetes insipidus, we have already learned that water intake was actually a corrective measure. So if in a patient with diabetes insipidus, water is restricted, his condition will start deteriorating. His laboratory abnormalities will also become worse. So this is the basic principle. And so you measure serum osmolality, you measure urinary volume, and you measure urinary osmolality. If patient actually has diabetes insipidus, by restricting water, he will continue to pass urine, dilute urine, and his serum osmolality will start rising and his sodium will start rising, and urine will continue to be of low osmolality. But if there is improvement, patient's urine volume starts reducing and urinary osmolality start increasing, and serum osmolality, which was likely to be low to begin with, start rising. That would mean it was primary polydipsia. I hope I have cleared the concept. So both are different conditions. Very important thing is that you observe the patient when you do this test, and it has to be in the hospital setting, and you be vigilant and to terminate the test anytime. When do we conclude the test? when patient has lost at least 3% of his body weight, or patient has fulfilled the definition and you have documented that in this case urine has become little, patient is urine is still dilute and serum osmolality has risen further, sodium has risen further. In this condition, you have confirmed that urinary volume has reduced and urinary osmolality has started increasing. So I think by that time you were convinced which condition, and then you stop that test. But if patient falls in this group, after observation, patient continue to pass dilute urine, then you consider diabetes insipidus, either central diabetes insipidus or nephrogenic diabetes insipidus. Now, how do we differentiate? One way is to measure ADH, which is not routinely available in our country. So what we do is, if we administer anti-diuretic hormone, and this one is available, there's something called DDAVP. So if we administer anti-diuretic hormone and then see the response, if there is improvement, we continue water deprivation test, but we inject anti-diuretic hormone. If there is improvement or in all the parameters, that means anti-diuretic hormone was actually deficient. And once we replace anti-diuretic hormone, conditions started improving. Improvement means urinary volume will reduce and urine osmolality will start increase. So that will confirm central diabetes insipidus. We will still have to go one step further to determine the cause of central diabetes insipidus by imaging tests, but at least we are sure that this is central diabetes insipidus. If imaging tests are negative, that would confirm that this is idiopathic central diabetes insipidus. Now, if there is no improvement despite ADH secretion, in these patients with primary polydipsia, there is already actually excess of ADH. Even in patients with nephrogenic diabetes insipidus, there is excess of ADH. Injecting ADH will not make any difference. So if you have come to this level and administration of antidiuretic hormone does not lead to any improvement, this would mean that patient has got nephrogenic diabetes insipidus. So this is the interpretation of water deprivation test or water restriction test. To sum up again, this is the test where you observe the patient's urinary volume, urine osmolality, serum osmolality under observation. You measure them, and then if things start improving, that means diabetes insipidus. If if the things start improving, it is psychogenic polydipsia or primary polydipsia. If things continue to deteriorate, that means it is diabetes insipidus. This is where you have to be very, very careful. You don't want your patient to end up in complication. And the moment you are sure that this is diabetes insipidus, you must stop. And then to differentiate between central diabetes insipidus and nephrogenic diabetes, you administer ADH and see the response. So water deprivation test is very useful. The treatment, now it would depend on the cause. If this is central diabetes insipidus, we have to replace antidiuretic hormone, and a synthetic form of antidiuretic hormone, desmopressin, is available. It has got a long name but short as DDAVP. This is available in the form of injection, which of course are not suitable for long-term treatment, but it is available in the form of nasal spray as well as tablet. So that has to be given for life for central diabetes insipidus. And if this is a nephrogenic diabetes, of course we have to see what is the cause behind nephrogenic diabetes. If that is correctable, we should correct that, but otherwise hydrochlorothiazide. Now students might be surprised that hydrochlorothiazide is a diuretic itself. How could that work in patient who already has polyuria? But due to some mechanism which is not exactly clear, but it does help in patient with nephrogenic diabetes insipidus. So that complete our lecture on diabetes insipidus, both nephrogenic as well as central diabetes insipidus. We also discussed about a similar condition called primary polydipsia. So I hope you like this video, and I'm really looking forward to see you in my next presentation, which I'm going to release very shortly. Thank you very much for your viewing.